think we can start. So good afternoon, everyone, and welcome. Thanks for joining here in person and also online. Today, we are going to have our Comprehensive Cancer Center Zürich seminar series. And today, it's my pleasure to present the highlights of oncology and Hemato-Oncology 2024. And before I start, I would like to thank the sponsors, as always, for their support. And I also give outlook on what this seminar series holds up for you in the upcoming weeks and months. Okay, so now I switch to my presentation. So, it's my pleasure today, I think for the third time, to give this retrospective on the highlights of Hemato-Oncology of the previous year. And I have to say that 2024 has been rather successful in Hemato-Oncology. There have been quite a few interesting studies and also approvals, as you will see later. So these are my disclosures, and this is my agenda. So I decided to make it more selective and focused instead of trying to give a comprehensive overview, which is an Herculean task anyways. So I nevertheless try to give you a broad overview about the full range of Hemato-Oncology, so ranging from acute myeloid leukemia all the way through the mature and immature also lymphoid diseases. So without further ado, I would just jump right into the first topic that I would like to discuss, and that is acute myeloid leukemia. And I would like to focus and talk about a new class of drugs, menin inhibitors, that are being tested and developed in the context of relapse refractory KMT2A rearranged and NPM1 mutant leukemia. So you may ask why exactly in these genetically defined subsets of AML. And that's the reason why I would like to give you a little bit on the mechanistic background on menin inhibition. So what is menin? So menin is a protein that forms these complexes with several other proteins, but most importantly also with this lysine methyltransferase KMT2A. And it does so also in normal hematopoietic stem cells, and it's very important for driving stem cell self-renewal. So in NPM1 mutant leukemia and also in the context of KMT2A rearranged leukemia, this interaction between menin with either wild-type KMT2A or also the fusion protein is really hijacked by the leukemias and drives the same aberrant self-renewal program. And these menin inhibitors work by disrupting the interaction between menin and KMT2A, and that basically overcomes this aberrant self-renewal and induces differentiation into mature myeloid cells. There are currently several menin inhibitors in advanced clinical development, and the drugs revumenib and ziftomenib are most advanced. I would like to summarize the data that has been published in 2024 in these studies here, the AUGMENT-101 trial and the COMET-01 trial, testing revumenib and ziftomenib as monotherapy in relapse refractory AML patients. And the target population is always NPM1 mutated patients and KMT2A rearranged patients. And the overall response rate is somewhere in the range of 40 to almost 60%, depending on the genetic subtype, and with a CR/CRh rate of about 30%. And in the responding patients, the response is actually very deep, achieving also MRD negativity. So a few words on safety with these drugs. These are new drugs, so there are also new safety signals that we have to acknowledge here. And one is QTc prolongation. This is particularly a problem or a concern and an issue with revumenib. But differentiation syndrome is really something that is observed in both drugs, and it is sort of expected because that's the mechanism of action of these drugs. Especially in the context of ziftomenib, for unknown reason, this was very severe, particularly in the KMT2A rearranged subpopulation of patients, and this probably has contributed to the relatively lower overall response rate that you can see that you can see here. And because the patients had to discontinue ziftomenib earlier. And also the company decided actually to discontinue the clinical development of ziftomenib in the context of KMT2A rearrangements. But nevertheless, revumenib shows really promising activity. It was also the reason why very recently has been approved by the FDA for relapse refractory patients with KMT2A translocations. And ziftomenib has been granted breakthrough therapy designation in NPM1 mutant AML in April last year, and is definitely a drug to watch out for. What's probably even more interesting than these drugs, menin inhibitors in a monotherapy setting, is when you combine them with standard chemotherapeutic drugs, especially the combination of aza-ven and in addition revumenib, this triplet in first line for patients with KMT2A and rearranged leukemia and NPM1 mutant leukemia. There was an interesting abstract at EHA this year. There was actually one session that was only dedicated to menin inhibitors. And this abstract I would like to present was, as I said, presented at EHA, and it tested exactly this triplet combination of revumenib, azacitidine, and venetoclax in the patients that are 60 years or older and who are not candidates for intensive induction chemotherapy and that have these mutations that I talked about already so often. So here, this is the study design. So basically, azacitidine, venetoclax as per standard FDA label, 28-day cycles, and then orally given revumenib. And after one cycle of this induction therapy, there was an assessment of the potential for marrow remission. And if there was marrow remission, then the patients were allowed to recover their neutrophil and platelet counts and then went on to the indefinite continuation phase. And if there was absence of AML clearance, then patients could receive up to 3 cycles. And then again, if there was no marrow remission, they went off study or they could be included in the continuation phase. Here, a few words on the patient characteristics and demographics. So it was an older patient population, per definition. Median age was 70, and about 2/3 of patients were NPM1 mutated, about 1/3 KMT2A rearranged. And before I show you the results, I mentioned already the adverse events, and as expected, differentiation syndrome and also QT prolongation was observed. However, this was rather self-limiting and also did not lead to any dose reductions or discontinuations of the triplet combination. Here are the clinical outcomes. So it's a small study, of course, only 24 patients were clinically evaluable for responses, but the overall response rate was really high. It was 100%, does not get any better than that. And also the composite CR rate, CR, CRh, and CRi was 96%. And also the patients that responded had fairly deep remissions with MRD negativity achieved in almost all patients. And also the remissions were achieved only after one induction cycle in the majority of patients. So very interesting drug combination, and there will be a randomized phase 3 trial of this triplet combination that most likely also the HOVON, SAKK, and also we here in Switzerland will participate in. So moving away from menin inhibitors, but staying in acute myeloid leukemia, and now focusing on another molecular subtype of AML, that is those patients with FLT3 mutations. And also here, triplet combinations are being explored in first line for patients harboring these mutations. And just to give you a brief background, I guess most of you will know that the addition of the FLT3 inhibitor midostaurin to intensive induction chemotherapy is standard of care for fit and younger patients with FLT3 mutations. In older patients, azacitidine and venetoclax is the standard of care. However, those older patients that have a FLT3 mutation, they respond relatively poorly to that combination. And gilteritinib, this is a second generation FLT3 inhibitor, and this is standard of care in relapse refractory AML patients. And the combination of gilteritinib and azacitidine was a very logical next step to pursue in this particular patient population, older, unfit with FLT3 mutations, but results of the late-swing trial were sort of unexpectedly negative. And so now, at the moment, these triplet combinations of aza-ven plus gilteritinib look promising to further develop. And I would like to present the results of this study here that tested an aza-ven gilteritinib triplet treatment. It was, of course, early phase 1/2 study, a single center conducted at the MD Anderson Cancer Center. The patients that were included were either relapsed refractory FLT3 mutated AML patients or newly diagnosed FLT3 mutated AML patients that were unfit for intensive chemotherapy. And they received a standard azacitidine venetoclax induction, on top of it gilteritinib given during the 28-day cycle, and then there could be up to 24 consolidation cycles, which, however, contained reduced azacitidine and venetoclax in terms of days given during cycle, but continuously gilteritinib. And the primary endpoint was CRi rate in the phase 2 portion of the study. And this patient cohort, frontline and relapse refractory, I'm not going to go through all these details, but I can say older patients, mostly with intermediate or adverse risk, cytogenetics, mostly had FLT3 ITD mutations, not TKD mutations. There were co-mutations, of course, also in NPM1, but also about half of the patients had secondary type AML co-mutations that are known to confer a poor prognosis. So overall, probably a patient cohort that is representative of this rather challenging patients. So these are the results. In the frontline cohort, the modified CRC rate, so that included CR/CRi and MLFS, was 100%. Also in a relapse refractory setting, 68% mCRC is quite impressive. And also the responses were deep. MRD negativity was achieved in the frontline cohort in a majority of patients, and then with a median follow-up of about 20 months. The RFS and OS was 71% and 72% respectively, which is quite impressive in such a patient population. However, in the relapse refractory cohort, with an even longer median follow-up, the responses, although patients achieved remissions, then did not really translate into very much improved RFS and OS if you compare this to gilteritinib monotherapy. Safety and adverse events, I will say that the observed higher grade adverse events were expected from such a patient populations. However, with these triplet combinations, of course, hematological toxicity is an issue, and also here the median time to neutrophil and platelet recovery was rather longer than reported in the VALI-A trial that tested azacitidine plus venetoclax. But a bit reassuring was that the 60-day mortality in the frontline cohort was 0%. So it seems that the toxicities associated with this triplet combination seem to be manageable. This was also the conclusion of the authors. And right now there's a dose finding and expansion study of this triplet regimen ongoing. And for the future, there's a randomized study planned that compares the triplet regimen against the current standard of care of azacitidine and venetoclax in those FLT3 mutated patients. So moving on and coming to the next topic, which will be acute promyelocytic leukemia. This is a very rare subtype of AML, and we will focus on an even rarer subtype. And this is those patients that are high-risk APL patients. And I would like to quickly remind you what's the first-line treatment standard of care for standard-risk APL patients, so those that have leukocyte counts below 10,000. So in those patients, based on the APL-04/06 trial, the combination of L-trans retinoic acid and arsenic trioxide, ATO, the famous Lococo protocol is standard of care, as you can see here. For the high-risk APL patients, so basically those patients that present with a leukocyte count above 10,000, still the AIDA 2000 protocol that is ATRA-based but consists a lot of chemotherapy in addition, is considered standard of care in many institutions and is widely used, despite the fact that also chemo-free ATRA plus ATO regimens have shown encouraging results also in a randomized phase 3 trial and also in a non-randomized phase 2 trial. But these were smaller studies or subgroups in the case of the randomized phase 3 trial. So not all institutions had adopted this nearly chemo-free ATRA-ATO regimen for the high-risk APL patients. So the Apollo trial was presented at the plenary session at EHA this year. And this is the study that particularly focuses on these high-risk APL patients. These are the inclusion criteria. So they needed to be, of course, have the definition for high risk and then good performance status and adequate organ function. And this is the treatment schedule. So they tested the Lococo protocol, basically, so combination of ATRA and ATO with 2 initial doses of idarubicin given to control hyperleukocytosis and prevent differentiation syndrome in those high-risk patients. And this was compared against the AIDA protocol. And as I said, it's ATRA-based, but contains a lot of idarubicin, Ara-C, mitoxantrone, and has also a 2-year maintenance phase of 6-MPN methotrexate. And the primary endpoint was event-free survival. I'm not going through all the parameters that defined an event, but I would say that this was rather restricted. There were a lot of events that would normally not be counted as an event in other trials of that disease. Here are the results. So the Apollo trial recruited between 2016 and 22, so also at the height of the COVID pandemic, and that led also to a situation that not the originally planned 280 patients could be enrolled, but only 133. And now this was the report of the 120 patients that were evaluable for disease status, and the median follow-up of time was 31 months. And here are the patient characteristics. And again, I would just like to highlight that these were really high-risk patients. So the median white blood cell count was 33,000, and there were even patients included up to more than 400,000 leukocytes. So these are really high-risk patients. As expected, we're looking at toxicity. The nearly chemo-free ATRA-ATO regimen was much better tolerated in terms of hematological toxicity. Other toxicities, QT prolongation is an issue or can be an issue with arsenic trioxide, and it occurred in those patients treated, however, at a relatively low frequency and was absolutely manageable. Here are the induction outcomes, no difference in terms of attainment of CR, and also early deaths were not different between the 2 treatment groups, but there were more relapses in the ATRA chemo as compared to the ATRA-ATO arms. And therefore, it doesn't come to a surprise that the primary endpoint, 2-year event-free survival, was met, statistically significant. There was no difference in overall survival, and likely will not be also with longer follow-up, because the relapsing patients can, on average, relatively easily be salvaged with the ATRA-ATO combination then. So the ATRA-ATO combination is most likely the new standard of care for these high-risk APL patients, and we had adopted this strategy already based on the earlier studies, but I think this will now be widely adopted. So now moving away from AML and entering the field of myelodysplastic syndromes, and I would like to present data for patients with low-risk MDS. And just to remind you, so the main clinical problem of patients with low-risk MDS are cytopenias and most importantly anemia, and indeed almost all of the patients will eventually become red blood cell transfusion dependent, and the mainstay of therapy is therefore erythropoiesis stimulating agents, so EPO, and this is of course helping, but it will also eventually, most of the patients, not be a longer term improvement in the hemoglobin levels. The patients will experience, they will lose their response to ESAs, and also some patients won't be eligible for ESA therapy as they have high endogenous levels of erythropoietin already. So for these patients, ineligible or resistant to ESA. Imetelstat is a new drug on the block. It's a first-in-class oligonucleotide that specifically binds to the RNA template of human telomerase. And just to remind you, telomerase is a ribonucleoprotein complex consisting of the protein part that's TERT and the RNA part that's TERC that provides the template for the addition of the telomere sequences. And imetelstat basically acts as an antisense nucleotide and inhibits therefore the telomerase complex. And it's supposed to work in cancers and also in MDS stem cells because these are believed to have higher aberrant levels of telomerase that would provide a window of opportunity for treatment with this drug. So therefore, the IMerge study tested imetelstat in this international double-blind placebo-controlled randomized phase 3 trial. Eligibility criteria for patients were, as I said already, low-risk MDS, relapse or refractory to ESA treatment, or ineligible because of high EPO levels. And they had to be red blood cell transfusion dependent over the previous 8 weeks in a 16-week pre-study period. And non-deletion 5q MDS, and also no prior therapy with lenalidomide or HMAs. And the patients were randomized in a 2-to-1 fashion to imetelstat or placebo, and the primary endpoint was red blood cell transfusion independence for 8 consecutive weeks. A few words to patient and disease characteristics. The populations in these 2 cohorts were well balanced. I will just quickly highlight that the patients really had a high transfusion burden, as you can see here, and they were similar in terms of being refractory to ESA or ineligible due to the high endogenous EPO levels. So these are the results. It was a positive study. The primary endpoint, red blood cell transfusion independence for 8 consecutive weeks, was met. 40% in the imetelstat group, 15% in the placebo group. Also, the responses were durable. Almost 20% of patients were still responding after 1 year of treatment, and the median duration of red blood cell transfusion independence, I think an important parameter in those patients, was highly statistically significantly different, 51.6 weeks in the imetelstat group, as you can see on the right-hand side. And also the increase in hemoglobin levels was clinically meaningful, 3.5 grams per deciliter in the imetelstat group. Safety. The drug is not devoid of safety issues. It has been studied previously in other indications, myelofibrosis, and from that we knew already that neutropenias and thrombocytopenias can occur. It was also the case in the study. Here in the IMerge study, however, they were mostly reported during the initial therapy cycles and then later seeded. And although 75% of the patients received dose modifications, only less than 15% had to discontinue. And also non-hematological AEs were mostly low-grade, and particularly liver toxicity, which has previously been reported, but seemed to not be such of a problem here in this IMerge study. So the conclusion was that it provided a clinically beneficial rate and duration of red blood cell transfusion independence. It's also the reason why in June 2024, the FDA approved imetelstat for exactly that patient population and indications as I described. Now I would like to move on to chronic myeloid leukemia and present data from the frontline asciminib trial, the ASC4FIRST trial. And a few words on CML. You all know that tyrosine kinase inhibitors have revolutionized the treatment of CML patients, but even with all these different first, second, third generation TKIs, intolerance or acquired resistance is still a problem in these CML patients, and that's why asciminib was developed as a first-in-class BCR-ABL allosteric inhibitor that specifically targets the ABL myristoyl pocket. It's also called STAMP inhibitor, this class of drugs, therefore. So what's the myristoyl pocket? So the normal ABL has this N-terminus that has this post-translational modification called myristylation, and this basically flaps over and goes into this myristoyl pocket, and that renders the ABL protein then in the inactive state. It's a form of auto-inhibition. Now, in the case of the fusion protein, this N-terminus is lost and is replaced by BCR, so nothing can flip over. So this is why the fusion protein is constitutively active. Now, asciminib was designed to specifically target that little pocket here and shifts the B-cell fusion protein towards the inactive state. And this works quite nicely, and that's the reason why asciminib was already approved in 2021 by the FDA for CML intolerant or resistant to more than 2 TKIs or with the gatekeeping mutation T315I. So now we are talking about asciminib in first line, so newly diagnosed patients with CML in chronic phase that had no prior therapy. This was a multi-center open-label randomized phase 3 trial, and the randomization took place 1-to-1 to either oral asciminib or investigator-selected TKIs. And the primary endpoint was achievement of major molecular remission at week 48 versus all investigator-selected TKIs and versus imatinib. And the key secondary endpoint was the MMR at week 48 versus all the second-generation TKIs. I will skip over the patient characteristic. It was fairly well balanced, and just show you the results. So this was a positive study. The primary endpoints were met. The rate of major molecular response was 67.7% in asciminib and 49% against all other TKIs. Against imatinib, it was even higher, 69.3% versus 42%. But the secondary endpoint, asciminib against all the second-generation TKIs, was not met, not statistically significant difference. Also, time to molecular response, time to MMR was faster in all the different analyses. Safety, there were safe adverse events in all of these treatment groups. However, overall, grade 3 and higher adverse events were lower with asciminib compared to the TKIs, and also treatment discontinuations were needed in fewer patients with asciminib than with the TKI treated patients. So in summary, asciminib demonstrated superior efficacy against the investigator-selected TKIs and also against imatinib, but importantly not against the second-generation TKIs. It definitely has a very favorable safety profile, but longer follow-up will be needed to assess really the long-term toxicities that could occur. It's not a magic drug because already in these trials and also in different studies, we know that also resistance against asciminib can occur, and we know the mechanisms by this. But nevertheless, this is now another treatment option for first-line patients with newly diagnosed CML based on the FDA approval that was granted end of October. So now moving away from the myeloid malignancies, I would like to enter the lymphoid field. And first of all, I would like to talk about acute lymphoblastic leukemia and about blinatumomab in MRD negative patients. Again, to give you a little bit about background on the treatment of BALL in adults. So really the use of pediatric-inspired intensive multi-agent chemotherapy protocols has really dramatically improved the outcomes of adult patients with B-cell ALL, and many patients achieve long-term remission. And the most important predictor of long-term survival will be achieving MRD negativity. But it has to be said that even patients achieving MRD negativity will still experience relapses. And this is where the ECOG-ACRIN E1910 trial comes into play, that tested the addition of blinatumomab to consolidation chemotherapy as a means to improve outcomes of those MRD negative patients. So blinatumomab, most of you will know, is a bispecific T-cell engager that binds both CD19 and CD3. It is FDA approved for the treatment of relapse refractory CD19 positive BLL. It's also approved for the treatment of CD19 positive BLL that is MRD positive. But now we would like to focus on the MRD negative population. So this study, it was a multi-center randomized open label phase 3 trial. Patients between the ages of 30 and 70 with newly diagnosed Philadelphia negative BLL were randomized, were included. And then when they achieved, of course, morphological remission and also MRD negativity, they were randomized 1-to-1 between the chemotherapy only comparator arm and then the chemotherapy arm plus blinatumomab, where the same chemotherapy was applied but interspersed 4 cycles of blinatumomab, and then there was also a 2.5-year maintenance therapy. Primary endpoint was overall survival in the MRD negative patients, and here are the patient characteristics. Again, fairly well balanced. I would just like to highlight that really 40% of the patients were older than 55 years of age. So this is something that needs to be kept in mind. Here's already the results. So in those patients that achieved MRD negativity, the addition of blinatumomab to consolidation really had a huge impact on overall survival, highly statistically significant, hazard ratio 0.41. And importantly, as one might have thought, this benefit was not really restricted to the older patients that do, in general, more poorly than younger patients, but it was actually on the contrary. So really throughout all the different subgroups that were analyzed, and especially in the younger patients, younger than 55 years of age, the addition of blinatumomab improved this outcome here. Safety, just quickly mention that, of course, blinatumomab associated adverse events, so basically neuropsychiatric adverse events, were of course more obvious and more prevalent in the blinatumomab plus chemotherapy group. Nevertheless, this was a really pivotal trial, and really the improvement for these MRD negative patients was very impressive, and overall the therapy was well tolerated, and that's also the reason why in June last year the FDA now approved also blinatumomab for all comers, also for the MRD negative patients. I would like to stay in acute lymphoblastic leukemia, but now look at the relapse refractory patient. So for relapse refractory B-ALL patients, there are multiple treatment options theoretically available, and the choice of treatment will depend on the prior therapies, on the age, comorbidities, what's the treatment goal, and also the availability of drugs and treatment options. And this includes blinatumomab, CD22 directed therapies, allotransplant, but also CAR T cells. And we have 2 CAR T cell products that are approved for adult patients with relapse refractory BLL, and that is Tezacel, however, with the upper age limit of 25 years, but more importantly, Brexacel, that does not have any upper age limit. So both these CAR T cell products, they use the same high affinity single chain variable fragment to recognize CD19, and these studies that are mentioned here on this slide really showed high rates of remission, but also considerable toxicities. And this is where this new CAR T cell product, Obe-cel, sets its goal. It uses actually a different single chain variable fragment that was chosen to have only intermediate affinity for CD19, because based on preclinical data it was hypothesized that this might reduce toxic effects and also improve CAR T cell engraftment and persistence over time, which could contribute to lower toxicities and maybe better long-term disease control. So this is the Felix study, and as often in the CAR T cell field, this is a phase 1b/2 study. Adult patients with CD19 positive relapse refractory BLL were included, also Philadelphia positive ALL patients if there was no other treatment option for these patients. And a total of 127 patients were enrolled. And then they did something which is rather unique in this setting. That is, they gave the CAR T cells in a disease burden adapted manner. So patients with high and low blast counts in the bone marrow, the threshold was 20%, were to receive either 100 or 10 times 10 to the 6 CAR T cells. And if the patients did not develop CRS greater than grade 1 and also no ICANS, then they received a second CAR T cell infusion 10 days later. This is also something rather unique in the CAR T cell field. And the primary outcome in the phase 2 portion of the trial was overall response rate. So these are the patient and disease characteristics. And again, it's a lot to dive into, but I would also just mention that 20% of the patients were older than 65 years of age, and they obviously also included patients up to the age of 80. And these were really a patient population that was heavily pretreated. 50% of the patients were refractory to the last line of therapy. About 30 to 40% had already received blinatumomab or inotuzumab, and some already both of the drugs, and also about 40% of the patients had already received an allogeneic stem cell transplantation and had relapsed from that. So this is the efficacy. I would focus on the phase 2 portion, and I forgot to mention that there were actually 3 cohorts, cohort A, B, and C, depending on whether they had morphological relapse, so blasts greater than 5%, or just MRD positivity or extramedullary disease. Most of the patients were included in the cohort R, 94 patients, and the CR/CRi rate was really impressive, ranging between 77, 186% in the different cohorts A, B, and C, and overall, also including the patients from the phase 1B portion of this study, the CR/CRi rate was 78%. These are very good results, and also in terms of survival, EFS and OS with a median follow-up of 20.3 months. The 12-month estimated EFS and OS was 49.5 and 61.1%. And as you can see here, there seems to be a plateau. Of course, it needs longer follow-up, but it's still noteworthy to mention that only 20% of the patients who responded to obe-cel underwent allo transplant, and still we are seeing this maybe plateau here. So the efficacy results are very nice, are very impressive, but they are more or less within what has been reported also with Brexucell. What's really unique and I think astonishing is the safety and adverse events. So even in those patients that had high disease burden, defined by a bone marrow blast percentage of greater than 75%, even in those patients, grade 3 or higher, CRS or ICANS was only observed in 2 or 12% of the patients, and in the total cohort, it was only 2 and 7%. And to put this a little bit into perspective, so in the Brexucell, the ZUMA-3 trial, the rates of grade 3 or 4 CRS or ICANS was in the range of 25 to 35%, and about 30% of the patients received vasopressors that had to go obviously to the intermediate care unit or intensive care unit. So compared to that, again, it's a cross-trial comparison, but obe-cel seems to do quite favorably. And also that's what the authors for the FELIX trial summarized. I mentioned already that there seems to be a plateau and that few patients actually had consolidative stem cell transplantation, and they looked at that, of course, in a non-randomized fashion, but there seemed to be no EFS or OS benefit in patients in remission after obe-cel treatment that received a stem cell transplantation as consolidation. So the FDA approved obe-cel very recently in November for adults with relapsed refractory B-cell ALL. And what's also noteworthy is that's the first and only CAR T-cell product that comes without a so-called risk evaluation and mitigation strategy, something that the FDA requires the centers that want to do these CAR T-cell therapies to comply with in order to mitigate potential side effects. So theoretically, this would allow obe-cel to be given also in an outpatient setting, which is quite remarkable, I think. Now, moving away from the immature lymphoid disease and moving into mature cells, and I would like to talk about advanced stage classical Hodgkin's lymphoma. And also as an introduction, I would like to say that really the development of these multi-agent intensive chemotherapy protocols combined with radiation therapy and also PET guidance has really dramatically improved the treatment and the outcomes of advanced stage Hodgkin lymphoma patients. However, there's no worldwide standard for the treatment of these patients. We here in Europe tend to use these combined modality treatments, escalated BRCOP, PET guided, and more recently then I presented the data of the bracket regimen, the HD21 trial last year. And then also radiotherapy, so this combined modality treatment options, what we here mostly use in Europe and also in Switzerland. In the US, although escalated BRCOP and I think also bracket are also mentioned by the NCCN guidelines, really it's almost never used. The standard of care in the US is brentuximab vedotin, so anti-CD30 directed antibody drug conjugate in combination with AVD, and this is based on the Echelon-1 trial that reported PFS and OS benefit compared to the comparator ABVD, which used to be the standard of care for those patients in the US. However, BV-AVD is associated with more toxicity, myelotoxicity, neurotoxicity, and also given that the PD-1 pathway is so essential for the pathogenesis of Hodgkin's lymphoma, and given that checkpoint inhibitors have really remarkable efficacy in the relapse refractory setting, but also in the frontline setting in Hodgkin's lymphoma patients. The SWOG 1826 trial compared the combination of nivolumab plus AVD against the still current standard in the US, BV-AVD. This was an international randomized open-label phase 3 trial. Adolescents and also young adults were allowed to be included in this study. They had to have newly diagnosed stage 3 or 4 classical Hodgkin's lymphoma and good organ function, and the other parameters that you can see here. It was a big study. Almost 1,000 patients were enrolled and randomized 1-to-1 to these two treatment arms, and this was not PET guided. There was only done imaging at baseline and at end of therapy, and this end of therapy imaging recommended PET-CT was then also used to decide whether or not, at the discretion of the treating physician, end of therapy radiation therapy would be applied to residual FDG-avid lesions. The primary endpoint is progression-free survival. These are the patient characteristics. Just will say that really from 12-year-olds up to more than 80-year-olds, a wide range of ages, diverse ethnic backgrounds. There were no lower stage diseases enrolled, unlike the HD21 trial, who also enrolled patients that had stage 2B disease, and also looking at the presence of B symptoms and high IPS scores. This was truly a high-risk classical Hodgkin's lymphoma patient population. This is the primary endpoint, progression-free survival. It was obviously a positive trial, statistically significant hazard ratio 0.45, no difference in overall survival. Yet in this trial, when we talk about safety and adverse events, it needs to be mentioned that there were sort of unexpected a higher rate of neutropenias in the patients that received nivo-AVD. There's most likely due to the fact that G-CSF support was not required in that patient population, but was required in the BV AVD protocol based on the prior experience with this rather toxic, myelotoxic regimen. Of course, immune-related AEs would be expected to occur more often, but surprisingly did not really occur more often in the Nivo AVD arm. The conclusion based on these impressive results, it's probably going to be the new standard of care for advanced stage Hodgkin's lymphoma, at least in the US. Probably not much change for us here in Europe, but I will say one thing that I found remarkable is, of course, this might be an interesting treatment option for older patients. Remember, there were also a fair proportion of patients beyond 60 years of age, and also end of therapy, radiation therapy was only needed or applied in less than 1% of the patients with Nivo AVD, and as comparison in the HD21 trial, 14% of patients received end of therapy radiation therapy. So it could be an interesting option, especially for older patients for us. Now moving on to diffuse large B-cell lymphoma, and here I would like to focus on relapsed refractory DLBCL patients ineligible for high-dose chemotherapy and autologous stem cell transplantation. And here would like to look at the glofitamab plus chemo combination, the STARGLO trial. Again, a bit of background for those who are not so familiar with these diseases and this clinical setting. So patients that have primary refractory DLBCL, or those who relapse within 12 months after end of first-line therapy, CAR T-cell therapy has been established as the standard of care. But there are patients for which there's still the need for treatment option, and these are the patients that relapse later than 12 months after end of first-line treatment, and those who do not have access to CAR T-cell therapies, maybe not so much of a problem here in Switzerland, but also patients that are ineligible for high-dose chemotherapy and autologous stem cell transplantation, which would still remain a reasonable treatment option for those late relapses, or for patients that have rapidly progressive disease that need an effective treatment option as a bridge to CAR T-cell or maybe a bridge to autologous transplantation. So here, glofitamab is an interesting player. It's a bispecific antibody similar to blinatumomab that I presented before, but it targets CD20, as most of you will know, and is approved in the setting as monotherapy in the setting of relapsed refractory DLBCL patients that have received 2 or more previous lines of therapy. Now, the STARGLO trial, an international randomized open-label phase 3 trial, tested the addition of glofitamab to the chemo backbone of gemcitabine oxaliplatin and compared this to rituximab GEM-OX. And this was a 2-to-1 randomization of patients 18 years or older, good performance status, relapse refractory DLBCL that had at least received 1 prior systemic therapy and that were for some reasons high-dose chemotherapy and stem cell transplantation ineligible. Randomization 2-to-1, and the primary endpoint was overall survival. And again, just quickly to highlight what kind of patients were treated in the STARGLO trial, 2/3 were really older than 65 years of age, and all of the patients had 1 or 2 previous lines of therapy. Very few patients had CAR T-cell therapies or a previous high-dose chemotherapy and ASCT. And also noteworthy, 2/3 of the patients had refractory disease to the last line of therapy. So really a patient population that it is in an urgent need of an effective treatment. And this is the primary endpoint. Overall survival was statistically significant with a hazard ratio of 0.6. And this impressive overall survival difference is, among other things, probably also driven by the higher rates of a CR, more than doubled in the glofitamab GEM-OX cohort. And when it comes to safety and adverse events, I'm not going through all of this, but I will say that there was a higher incidence of AEs in the glofitamab GEM-OX cohort, but these patients also received more therapies, so a median of 11 cycles as opposed to only 4 cycles, and the rituximab GemOx. And of course, some of the reported AEs are known to be associated with glofitamab and only occurred in that patient population. And I'm talking about CRS and neurological events due to the immunotherapy. So in conclusion, this is definitely a very interesting combination, highly clinically effective and clinically meaningful with a manageable toxicity profile. And the authors conclude that this combination represents a new and readily available treatment option for these patients of an unmet clinical need. And the FDA is expected to make a decision by summer this year. Now coming to multiple myeloma, really the last year has seen multiple studies that tested the addition of anti-CD38 antibodies in combination with VRD, both in newly diagnosed multiple myeloma patients that are transplant eligible, but also transplant ineligible. And I would like to just quickly summarize the main findings. First, in the patients with that are considered transplant eligible and that will receive an autologous transplantation. There was the Perseus trial and the German HD7 trial that tested the addition of daratumumab to VRD against VRD, or the combination of isatuximab, the other CD38-directed monoclonal antibody, plus VRD also against VRD. So very similar studies. Same primary endpoint, progression-free survival, almost the same median age, similar follow-up, and similar high rates of overall responses, not necessarily different between the treatment groups, but deeper responses, more CRs, more MRD negativity, and also in both studies, a progression-free survival benefit, no overall survival benefit yet. And based on the results of the Perseus trial, the FDA approved daratumumab in combination with VRD in the transplant-eligible newly diagnosed patient population in June 2024. Now, coming to the patients that are transplant ineligible, and here the IMROS trial was published in New England Journal of Medicine and compared isatuximab VRD versus VRD, now without high-dose chemotherapy and autologous transplantation. The primary endpoint was progression-free survival, median age of the patients expectedly higher, 72 in median, and the median follow-up was almost 5 years, and again, high rates of overall responses, and again, deeper responses with the addition of isatuximab, and the primary endpoint was met. PFS was significantly longer in the quadruplet combination than in the triplet, and again, also no overall survival difference, as always with these patients and these studies in multiple myeloma. And the combination of isatuximab plus VRD was approved by the FDA recently in September for the newly diagnosed multiple myeloma patients who are not eligible for autologous stem cell transplantation. Now, VRD is a treatment option for these transplant ineligible patients, but another treatment option, and in fact standard of care in many institutions, including ours, is the combination of an anti-CD38 antibody, so daratumumab plus lenalidomide and dexamethasone. So based on the MAIA trial. So it's now a bit of a question whether the addition of bortezomib is required and would provide a clinical benefit in those patients. And speaking of benefit, this is also the name of the study that tested exactly this question. It compared isatuximab VRD against ISA-VRD, so something similar than DARA-RD. And the primary endpoint in the study was MRD negativity at 18 months. We can argue whether this is a reasonable primary endpoint. Median age 73.4 years. Median follow-up was shorter. And again, there was the difference in the overall response rate, but mostly really the depth of remissions was different between the two trials, between the two treatment arms, and no difference in PFS with that short median follow-up, and of course also no overall survival benefit. So probably if your standard is VRD in those patients, then the addition of isatuximab is reasonable to do, and whether you have to change your current standard of practice from CD38 targeting antibody and RD to ISA VRD, I think still remains to be determined. Now, in the last couple of minutes, I will talk about smoldering multiple myeloma. That's a condition that rarely enters the center stage, but the results of the Aquila trial have been reported and published recently in the New England Journal of Medicine, and has gained some attention, and also wanted to discuss this result of this Aquila trial here in this audience. A little bit of background for those of you who are not so familiar with the concept of smoldering multiple myeloma. So this is a asymptomatic precursor state that is between MGUS and full-blown multiple myeloma, and per definition it's asymptomatic, and therefore currently the standard of care for this patient is watchful waiting. However, some of these patients will progress into multiple myeloma at a certain point. Some patients will stay in this smoldering myeloma state for a very long time. Some patients might never really develop a treatment indication. And there have been multiple studies that try to assess whether there is a clinical benefit of treating early these smoldering multiple myeloma patients. And the most recent trials were the CRE-REDEX trial and another ACRIN trial that tested lenalidomide plus minus dexamethasone, and again the results were conflicting. There was a PFS difference but not overall survival difference. So given that daratumumab is so effective in the first line setting and also relatively well tolerated, and based on the results of the phase 2 trial, the Centaurus trial that tested daratumumab monotherapy in those smoldering multiple myeloma that are at a higher risk of progression to manifest multiple myeloma, this Aquila trial was set up and the results were reported. So it was an international randomized phase 3 trial that randomized patients, and I will come to the eligibility criteria in a second, 1-to-1 to either daratumumab or active monitoring. And daratumumab was given for up to 36 months, and then a disease progression was regularly assessed in these patients. So eligibility criteria: adult patients, smoldering multiple myeloma within 5 years of diagnosis. The clonal bone marrow plasma cell content or fraction needed to be 10% or higher. That's the definition of a smoldering myeloma if there's no Krebs-Slim criteria present, but there had to be at least one other risk factor for progression to multiple myeloma. And those are listed here. And we have a risk score for smoldering multiple myeloma patients, so-called Mayo Clinic risk stratification. And I have to say that these risk factors here are different from what is typically been used to assess the risk of progression of smoldering multiple myeloma patients to full-blown multiple myeloma. Just to quickly mention that, it will become a little bit more important in a second. Primary endpoint was progression-free survival, and this was defined by using the SLIM-CRAB criteria. Here the patient characteristics, I think fairly well balanced. There was maybe a little bit higher clonal plasma cell disease burden in the active monitoring group, if you look at the percentages, and also maybe a little bit enrichment of patients with higher risk smoldering multiple myeloma according to that Mayo Clinic criteria. But other than that, fairly well balanced. And here are the results. Primary endpoint, progression-free survival was, I would say, of course, met, because everything else would have been a huge surprise given that daratumumab is an active drug in multiple myeloma, and was sort of expected, in my opinion, also to yield that difference in progression-free survival. It was also highly statistically significant. What's interesting is that also the curves for the overall survival separate, and that the hazard ratio of 0.52. I mean, looking at the confidence interval, it actually does not include 1, but there's no p-value given. I don't know, maybe because of some statistical additional parameters why this was not reported and stated as statistically significant. So does this now mean we have to treat our smoldering multiple myeloma patients with daratumumab monotherapy? I think we have to look at what type of events caused the patients to progress. So what's reassuring is that none of the patients died due to progressive disease. There were 5 deaths in each group, in the daratumumab group and also in the active monitoring group, but in both groups, these 10 deaths were without evidence for disease progression. So most of the progression events were then either CREB criteria or SLIM criteria. And if you look a little bit more careful at what caused the patients to progress, these were really rather on the lower end maybe of severity, that such a progression could be, meaning that there were no incidences of renal insufficiency, only 2 instances of hypercalcemia, actually no difference in bone disease, and basically it was driven by anemia and also by SLIM criteria. So I think it's questionable whether this would really warrant a change in practice based on progression-free survival. But there's an overall survival difference. But obviously, this was not driven due to deaths that occurred during the study, but was most likely driven by deaths that occurred after the patients progressed and then went off the study and received first-line therapy. And then it's important, I guess, to look at what kind of post-protocol therapy the patients received. And here's a little bit astonishing to see that only 1/3 of patients received daratumumab as post-protocol therapy, whereas all the other patients received it even on the asymptomatic stage of their disease. It was a positive study per definition. There was also an overall survival difference. Daratumumab is definitely well tolerated, and the authors, of course, also suggest that daratumumab monotherapy could be a treatment option for these smoldering myeloma patients, and it's also, I think, in the field expected. FDA will grant approval for this indication, but I highlighted a couple of concerns that we have to keep in mind when we assess whether this is going to be practice changing or not. And some of them are listed here. I wanted to make it in 1 hour to have enough room for discussion and not to use the full 1 hour and 50 minutes. I think I will almost make it because that's the last study I would like to test. It was the CLL-12 trial that tested ibrutinib versus watch and wait in early stage CLL. And for those of you who may notice that this is basically the same question as in the Aquila trial. So when to initiate treatment in patients that are asymptomatic and have a rather indolent and incurable disease. Because also in early stage CLL, the current standard of care, as most of you will know, is watch and wait. And this has been demonstrated based on trials that fail to demonstrate a difference in outcomes and survival outcomes between watch and wait and early intervention. But these studies were conducted in the olden times of when chemotherapy was given to those patients. Now in the modern era of targeted therapies and also having now better prognostic tools at hand that allow us to identify patients with early stage CLL that are more likely to progress to active disease. There was obviously the time to reassess whether the wait and watch strategy is still the best option for these patients. And this is the CLL-12 trial. It enrolled patients with treatment-naive BNA stage A CLL that don't have a treatment indication according to the IWCLL criteria, have a good performance status and a reasonable life expectancy. And then based on this German CLL study group score, and in addition, the TP53 mutational status, from which we know is associated with higher risk for disease progression, patients that had an intermediate high and very high score were randomized 1-to-1 to ibrutinib or placebo. And there was also a cohort of patients that were low risk according to this criteria that were just observed and used as a control. Primary endpoint was event-free survival. The ibrutinib and placebo cohorts were, of course, very well balanced. The watch and wait, of course, not, because they were low-risk patients. And therefore, I'm also only showing the data for the two randomized cohorts. And as you can see, and sort of again, as expected, EFS, the primary endpoint, was statistically different between ibrutinib and placebo. But when we look at deaths, there were only 12 deaths in total, 1 CLL-related, 11 other causes in the ibrutinib arm, and 14 deaths, 4 in the placebo arm, and 10 other causes in the placebo arm. So there's only a difference of 2 deaths between these two cohorts, and that would not, of course, translate into an overall survival difference. And other than daratumumab, which is relatively well tolerated, ibrutinib does have or does come at a cost of increased toxicities. We all know that cardiac arrhythmias, AFib, and bleeding are a problem. And indeed, almost 50% of the patients treated with ibrutinib discontinued ibrutinib after a median of 9.5 cycles because of adverse events such as arrhythmias. So the authors of that study concluded that yes, ibrutinib delays CLL progression. However, it comes at a significant cost of toxicities, and therefore, even in the era of targeted therapies, watch and wait will remain the standard of care for those early stage CLL patients. So with that outlook that sometimes less is more, I'm at the end of my presentation. Thank you very much for your attention, and I would be happy to take questions.
There is a slight delay with the catering, so we have time.
Thanks.
Yeah, thanks a lot, Steffen. I have a couple of questions. When you showed the action of inhibition by binding in this myristoyl pocket in CML, as with most good drugs, there is selection pressure for mutation, and then it doesn't work anymore. However, this is the binding site for the natural inhibition. And I was just wondering, is there any case reported where enable, the autoinhibition, doesn't work while there's no BCR-ABL translocation? Is that known to you?
I think the short answer is no, it's not known to me.
Because in theory, there could be natural mutations in the endogenous binding site. It's probably then
preventing this N-terminus to flap in and do the causing hyperactivation and driving malignancies as an oncogenic event. Yes, I think theoretically this could be it. Of course, it depends a little bit on complicated protein biochemistry, whether some mutations are likely to occur there in the right trinucleotide context, and whether then that would, I could think of, certain amino acids that are more bulky and could prevent this N-terminus to flap in.
But it's not something that's known.
Theoretically, yes, but I'm not aware of any case reports.
And maybe one other question, in the relapsed refractory B-ALL setting where obe-cel now is used, and it was done in a very smart way with this adapted to tumor bulk, accounting for effector to target ratios and T-cell activation, and double, sequential application of the drug. I think that's all great. There was one hypothesis associated with obe-cel saying that a lower affinity to the target would, in a way, mimic TCR MHC interactions and not deliver such a strong signal to the T cell. And that's why there will be not such a lot of activation-induced cell death, and then the cells also live longer and give a better protection. Did they show the maintenance of the CAR T cells in those individuals to prove that this hypothesis holds up?
I have to admit, I'm not aware, was it? I cannot recall from the top of my head. It might have been one of the secondary endpoints, and also I think they had also exploratory endpoints, but I'm not aware, and I cannot tell, and I have not the data in my mind. I think they did. Would have been very not smart to not do it, but I cannot.
I'm sure they did it. I just don't know whether they reported it.
I cannot tell. I'm sorry.
Okay. Mm-hmm. Thank you.
So thank you, Steffen, for this excellent overview. One question to the imetelstat trial, pronounced it right. So if I understood it right, we exchanged the need for transfusion against the need for an infusion, because I think imetelstat is given as an infusion once a month. Regarding this, were there any data provided regarding the symptoms or the quality of life that was improved by this? Because, I mean, you can question if you come to a transfusion or for an infusion for the treatment. Perhaps that doesn't change so much in the end, but you have, as you showed, some side effects by the treatment, right?
Yeah. Was quality of life reported? Again, I cannot tell if they did that. It should always be done in any clinical trial. I think it's a general lack in the conduct of clinical trials that patient-reported outcomes that do not play a major role. So I cannot tell. But of course, it's not just the frequency of having to come to the transfusion clinics. It's also iron overload and things like that. So and something also that I did not mention, because I don't know if I can believe into it. So if you think about how the mechanism of action is, so it should inhibit telomerase, which is supposedly higher active in cancer cells than in non-cancerous cells. You would expect, if that's the case, to be able to make the mutant clone contract over time to have an effect on the variant allele frequency. They mentioned it actually, and it was also an endpoint, but it was not reported in the main manuscript, only in the supplement, and it was, of course, I think not very convincing. So in addition to the transfusion independence, that's the reason why I'm mentioning this, is I think the hope with imetelstat is also that you have a disease-modifying activity, and you could actually suppress the clone. And I think that's the hope a little bit with that drug.
Thank you, Steffen. I have two questions about the menin inhibitors.
Yeah.
Maybe the first one, the NPM1 mutated AMLs, did they also include FLT3 mutated like you showed in the second trial, or were these only NPM1 mutated?
You mean in the triplet combination trial?
Yeah,
I showed all the monotherapy. Yes, there were also NPM1 mutated, FLT3 mutated patients, which is, I think, fair to include those patients because there is no approved standard. Okay, I think that's the reason why you're asking. So, is it fair to include a FLT3 mutated that also has an NPM1 mutation if you have another option? So, the triplet combination with gilteritinib, for example, is not approved. So I think it's fair to include the patients with NPM1 mutations that have also a FLT3 mutation to such kind of a trial. Picture will be different once in the future there will be maybe triplet combinations, and then you have to decide in those patients that have both mutations, how are you going to treat those patients? Yeah. But in that trial, yes, there were also FLT3 mutated patients.
And then you mentioned maybe there's a HOVON trial. So how long will it take? What do you foresee? How long will it take to get into the clinic if these trials are positive?
So I think what I can say is that this is currently, you know, in the contracting phase and in the setup. I hope this will be. I think it's in the public domain, but no specific information. But I hope it will be during 2025 that we will have these trials. And I think many companies that develop menin inhibitors will test their compounds in these combination settings, either with aza-ven, but also 3+7 for the intensively treated patients.
Thanks for a very nice overview. You showed the high-risk Hodgkin lymphoma data and the potential new treatment option, and you emphasized the reduction of radiation from 14 to 1%. Yeah. But why should that be a benefit for the elderly? I mean, I would assume this is in particular for the younger patients.
Yes, exactly. So this was a point that was made by the authors and conductors of the study, because they included also adolescents and young adults, and in those patients, not having to undergo radiation therapy would theoretically be a benefit in the long run. Yes, yeah. Or not for the sorry, that was maybe misleading. That could be a benefit, especially for the younger patients with Hodgkin lymphoma. Yeah. And maybe also as a comment, so I think your American colleagues there, they do not get the chance to irradiate that often. Even FDG avid lesions was always my understanding. So I think the medical oncologists and hematologists in the US are very reluctant even to irradiate FDG avid lesions at end of therapy. So that could also be, so I'm saying, cultural aspects why the fraction of end of radiation therapy was lower in that American trial as opposed to what we are doing here in Europe.